We start with therapeutic case review. We will use the pool. Okay, we can go to the first case briefly. This is a 60-year-old female with 10 years of smoking history, and we can see the low-dose CT images started in 2011. During 10 years, so first GGO lesion in the upper lobe. You can see it's measuring about 1.2 centimeter, then progressed in size during this 10 years to 2.8. And now a question: if we can ask the question, would you treat it now at this moment, or do an invasive diagnostics, or follow it up? So the question is, would you treat it now? 28 millimeter. No solid component. Yeah, so we can see still 23% of people want to go invasive, either diagnostic, either treatment. So we observed it. The next slide, please. And in 2025, in the next annual low-dose CT image, the radiologist observed the small consolidation in this lesion, and it progressed just a little bit in the diameter. So we decided to do the PET scan. In the PET scan, we have SUV 2.1 in this lesion, and we decided to do the biopsy. The biopsy showed AIS, AAH, and now the question: what kind of treatment do you propose?
You did not have a no treatment, approach. So
no treatment is not considered here because to make it.
Well, I think there was a question raised yesterday by someone who said, do you also look at coronal and sagittal views? So we would probably look at that.
Yeah, that was.
If it's creeping towards major blood vessels and things, and if it's more than 3 centimeters, patients and the tumor board gets nervous, but I would say that I would probably not treat it.
Not treat it at all?
We would follow them up.
Yeah, so 42% would do segmentectomy, 27, little bit less resection, SBRT, also considered, lobectomy 7%. So let's move forward. We did veg resection. So the final pathology was invasive papillary adenocarcinoma. So the biopsy was probably around the solid component where papillary adenocarcinoma was present, and the resection margin was 1.5 centimeter. Nearly 3 centimeter lesion with very small component and 1.5 centimeter margin. What would we do now? The next one, observation of or lobectomy. It is mainly for surgeons, but not only. Well, we have observation. We were discussing it because this is our current patient that we, I have to add that accountant of 3 of colleagues from our team. So we discussed it back and forth and we decided observation as well. Thank you very much for this. First case, I want to briefly also show you the next case, which is difficult for us also. So please move on. This is the patient that, this is the first CT performed, and what we can see. The problem is with this patient that this patient has multiple 9 GGO lesions. Quite big GGO lesions in both lungs and 1 solid tumor that is adenocarcinoma. And what should we do with this patient? This is for discussion. Do you have any concept how to treat this patient with 1 lesion that is about 2.5 centimeters, close to 3, and then GGO lesions, 1 of them probably part solid, the rest is rather GGO. What to do? Concentrate only on this one and observe the rest, or any other proposals?
I think, everyone takes these to tumor board and it's a slightly different decision sometimes. I think our approach in Toronto has been anything with any solidity comes out. And then the GGOs would normally be watched, although if they're very large or there's some concern about change, they might remove them. So, the solid lesion for sure, maybe the part solid lesion. We did a very old study a long time ago looking at multifocal disease and the sort of focal resection of the solid lesion. And we found that when we compared all of the different approaches, systemic therapy alone, local surgery, and this is old techniques, survival was similar. So certainly there's no harm to jumping in and intervening in the hands of, experienced surgeons like yourselves. How much does it contribute? I don't know. But it certainly doesn't seem to harm long-term in terms of survival. What would you guys do in the Netherlands?
But specific question, if we do the lobectomy, right upper lobectomy, the patient is in a good condition and good pulmonary status. We are doing upper lobe lobectomy. This is our current patient. And then you have left 6 GGO lesions, 2 parts solid, let's say. How many times can you do SBRT?
So if I understood the case from that one image, it's adenocarcinoma in a cystic space, correct? And it was 2.8?
This one.
No,
the solid lesion. Or the last one.
Not this one, the previous one. Oh, this one.
No, the previous one.
Yeah.
No, I'm talking about this one.
Oh, this one. Okay. No, my preference would be for surgery.
Yes, surgery, but what with the rest?
We can treat stereotactically, but...
How many of them?
Well, I think you look at the functional results. So you got an intense PET positive abnormality, and you got multiple lesions. And I would say, why not take out the solid lesion with an anatomical resection? If I treated this and followed up, I could also do it, but then I would be reluctant to treat all the GGOs. For us, the criteria is, my line will correct me if I'm wrong, if it's more than 5 millimeters, I think we are influenced by the Mill trial, I think. If it's more than 5 millimeters solid and is growing, then we would treat it. So if there's an indication to treat a second lesion, and I would say if I do 2 lesions and I'm almost causing a lobectomy, or 3 lesions, then I'd say, well, why not do a proper lobectomy with a node dissection?
So I think our approach would also be going for a lobectomy of the left upper lobe. You beat sort of 2 things in one surgery. You remove the tumor that is driving the prognosis, and you have additional GGOs in the left upper lobe as well.
Yeah.
So you can get a molecular testing of the primary lesion as well as of the GGOs, see whether it is true multifocal disease, all primaries, or whether some metastatic issue is present, and also get some information about the lymph nodes, and then you can decide whether on top of the local therapy, some adjuvant systemic therapy might make sense.
Thank you, and sorry that I couldn't show you all the lesions, but something happened here.
Okay, so we'll continue. I have a few cases I want to show, and depending on time, we can show a few more. I do have one comment on the first case that Witold showed, and since we only have one pathologist in the room, I get to pick on him a little bit. Eric, did you see that first case, the non-solid 2.5 centimeters roughly? The pathology, initial biopsy diagnosis said AAH, AIS. I think that's the pathology, but it influences people's thinking about what the lesion is. I would say AAH should not even be in the consideration for that as a diagnosis, and that's why I think pathologists do need to look at the imaging before they say things, before they make their diagnosis. And I know several pathologists now that say that they routinely check the images before they say, because that lesion, in my mind, AAH should not be in the consideration for something like that. What do you think?
There are at least two things. One is that the difference between AAH and AIS is in morphology a complete lining of tumor cells along the basement membrane of the alveolus. That's AIS. If you miss some spaces in between, then it's AAH. So there are several lesions which are AIS and have in the surroundings or at the edge some AAH options because there are less tumor cells on that local area. So in this case, I would just call it AIS together with little AH. You've got them also in your series in New York.
Yeah,
Yeah,
I'm familiar. But when you say AAH, it gives people in their minds the idea that, well, this is really, really nothing. This is, precancerous, and that's not. That is, just from the imaging, you never see. I've really never seen a 2.5 centimeter with that density come back with a pathologic diagnosis as AAH. Just a subtle point.
Yeah, so if I understand you correctly, you prefer to hear only AIS.
Yeah.
And not
probably
the
it's even more than that.
diagnosis of a little bit AAH on the side.
And if I gave that to you, you would find areas of invasion also on the final pathology. I'm sure of it.
This case was interesting because the biopsy was different from the resection.
Yeah.
Okay? Can you keep the microphone for a minute?
Professor Infante wants to say something?
If I may, it's more of a question or the second case that you've shown. I have two comments. One, the largest lesion that is very PET positive is close to a large GGO. They are both, it looks like they are both in the upper part of the left lobe. So we have some data that show that if you take only the 3 apical segments out and leave the lingula, you could do a lung sparing operation in such case. What would you think? And the second is the first lesion that you've shown in the right lower lobe, to me, looks like
Right upper.
what the right lower lobe.
Upper.
Sorry?
The first lesion was in the right upper lobe.
Can I see it? But anyway, it looks like what we call a complex cyst, that it's fairly associated with invasive cancer. So what this would make a case for lung sparing surgery despite the relatively large size of the PET positive lesions that you have shown. What do the panelists think? You think this is upper lobe? I don't think so.
No, no.
This one.
Yes.
This is the second case.
Yeah.
Yeah, that was one of the 9 lesions.
Yes. So
One like
I would.
this, and rest was, sorry I couldn't show you, but the rest was GGO lesions.
Okay. So this is fairly suspicious, isn't it? I think so. So do you think this is the case for lung sparing surgery on the other side or not?
Yeah. If we decide about the lobectomy, then we should go on with the limited resection.
I mean, lung sparing on the left.
Or we have an SBRT expert. Could you zap that, Professor?
Yeah, we were seeing a lot more of the cystic lung cancers. We just look at it coronally as well, make sure it's not too extensive. Sometimes, well, I think it's a pathology question. You know, if it's in a cyst, and where do you stop your margins? That's often the question. But yes, I think an anatomical resection on the left side, subsequently followed by stereotatic radiotherapy to this lesion, would be something very feasible.
In this lesion?
Yes.
I mean, it's certainly a valid point. We haven't seen the other lesions, how they look like. So if all of them look similar to that, I would still stick to the plan of resecting the solid lesion. But if it's the only lesion that looks like that and the others are really pure GGOs, then it's certainly a valid point of doing a lung-sparing resection on the left side as well.
We've been talking a lot about opportunistic findings in this conference. I would like to ask the medical oncologists, if you're treating a patient with a lung cancer and multiple non-solid lesions with chemotherapy, what happens to the non-solid lesions? Do they go away?
So for the most part, I mean, in my experience, and we've got Karen here as well, they actually stay the same. Sometimes they do change, but, does the chemo have anything to do with it? We don't know. So, I think we're all more enthusiastic about the impact of treatment on solid lesions. And then, for AIS, the impact of chemotherapy is minimal. Now, EGFR inhibitors, I think it's variable, but again, sometimes we don't see change. Sometimes we do, because sometimes we will start people on EGFR inhibitors that have multifocal disease, and we can see some improvement in GGOs. But again, it's not consistent, and the response in a ground glass lesion or AIS with EGFR mutant lung cancer is far less than a solid invasive cancer. I hope that
We have
helps.
Fred's talk also, yeah. But, okay, we got to move on to next
David,
cases.
Can you give me one small comment?
Small.
Yeah, on the case which was presented, because the biopsy was AIS-AH and the resection was papillary. So what happens during surgery, as different to a biopsy, the biopsy is still open because it's immediately punctured, but in surgery the air goes out. So if you have an alveolar,
We have props here.
if you've got an alveolus and you want to reduce the volume by taking out the air, you need to have some adaptation of the walls to get a reduced volume. And this adaptation gives you infolding of the alveolar wall, which may give, depending on the amount of air left, a papillary appearance. So it's not excluded that the resection is diagnosed as papillary carcinoma, where it is infolded AIS.
Having sat and watched him read pathology slides, he's been going over all of our I-ELCAP non-solid lesions and working with Mary Beth Beasley. And watching Eric is really quite a treat. Not every pathologist can think of it the way Eric thinks of it and measure the extent of invasion and what's papillary and not papillary, and listening to him explain the infolding. It's really something. Anyway, let's try the next case. This is a local recurrence adjacent to the suture line, status post right upper lobe, wedge resection, soft tissue thickening, and you can see 6 months after surgery, you can already see there's kind of nothing there. 6 months, 12 months, you see something. It's getting bigger. It's getting bigger. So what would you recommend?
I've got a question about radiologists, but I'm sure there are a lot of radiologists here, but Can this be a suture line granuloma? Or is that? Yes. Okay.
Okay. Well, let's assume it was already biopsied and it's malignant. Surgical resection, yeah. So surgical resection.
The resection was lobectomy? Primary?
You tell me.
No, primary resection.
Okay, surgical resection. So to me, this has always been a very interesting topic. You know, back in the day, this was considered a fatal, this was considered really a terrible finding, like stage 4. Suture line recurrences were considered very bad. Now, people are reoperating routinely. So, what do you think? Recurrent disease, adenocarcinoma, just surgery, limited surgery, lobectomy, what would you do?
Well, it's in a location that might be tricky to biopsy. I haven't seen the full slides whether it can be reached bronchoscopically. It's certainly an option to verify it in advance, but if it's growing in size, it's FDG avid, then a recurrence is likely, and I would go for a reoperation and then decide intraoperatively on the situation. But most likely it's going to be a completion lobectomy since it's located quite centrally.
Adjuvant therapy?
It depends on, I mean, I'm not going to cure this person with drugs, so I agree we need local therapy, whether it's either of my two colleagues to the left. And then it's going to depend on the pathology. I don't think just because it's recurrent, we necessarily, or, you know, is it recurrent or was it not removed? And, you know, I think we would look at the pathology and sort of treat it as a new issue rather than sort of M1 resected, you know, so we wouldn't, that's not how we would think of it. We would think of it as a new lesion. What would you guys do?
I think I would look at all the images. If the tumor board was convinced of a recurrence, I would want to see what is a likely...
It was biopsied. It was biopsied. It's
Okay.
known adenocarcinoma on the recurrence. Yes, your question was, could this have been a suture line granuloma? Yeah. Yes. It's an unusual shape for it, but absolutely it could have been.
So I would want to know the proximity to the airways, because with central SABR, I might actually cause a late lobectomy, late bronchial stenosis. So, and I would have to use a careful technique, 8 fractions, to try and spare the contralateral airway wall when I radiate it to limit the risk of subsequent late atelectasis. So stereotactic radiotherapy, but with a careful technique, which is more precise than our standard 3 or 5 fraction scheme.
You know, I very much appreciate your comment, and I'll tell you why. I really believe that we're getting to this point where we have to be thinking in cases like this, what's going to have the optimal success rate? Is it going to be surgery? Is it going to be radiation? And what are the factors that make one preferable to the other? And I think we're going to be facing that more and more with these stage 1s. Even, it's not just going to be comorbidity, is what I'm driving at. Right now, it's radiation only with advanced comorbidities. Instead, I think it's going to be other factors that should be driving this. And you just mentioned one, you know, proximity to certain airways, et cetera. But I really think we're heading in this direction.
In terms of prevention, you know, I wasn't sort of thinking about the adjuvant quite as clearly, but, you know, at tumor board, often if someone is a good candidate, we would discuss it as an option. But again, you know, it sort of depends on what it looks like, what's the genotype, what's the rest of the patient look like, what the patient is interested in. So it's always a tumor board discussion, and it's not necessarily the same answer each time.
Now, by the way, this was the lesion that was resected in this patient previously, and it had a tiny bit of solid component. Basically, this was a non-solid lesion. Does that impact what you think of that recurrence and what you would do? So the original lesion was non-solid, basically. The recurrence is a solid lesion. Do you care? What if that... It's a really interesting question, I think, because Why should the recurrence have been solid, number one?
Yeah.
We very infrequently see non-solid recurrences along a suture line. We see them occasionally, and especially after the original lesion was non-solid. But, you know,
And I guess, some of it is what's the molecular testing. So in Toronto, we would have been able to test the 8 millimeter part, but what is it now? And also this concept that you're describing that, somehow it's becoming more aggressive over time, and will that sway the tumor board to recommend more, a stronger preventive strategy? Again, I don't know how great the data are. I think the data are not great. So it really is a discussion and very subjective.
I agree. I mean, if you look at the sub-analysis also of the JCOG data, for example, the survival benefit of segmentectomy was largely driven by the age group above 70 years. So in the younger ones, it's much less. And if this is a 67-year-old patient, if the patient is fully functional, fit, I'd rather go for the safe option and do a completion lobectomy in this situation than risk another recurrence, necessity for another intervention. But I fully agree that the molecular pathology will help in classifying whether it's a second primary or a recurrence.
well, you can see the answer by the audience. Depends on the molecular profile was equal to the doesn't matter, this radiologic subtype. What if it was a non-solid subtype? What if you just saw non-solid along that suture line? Would you still be aggressive in following it? We see that. I mean, I've seen cases. It's fairly uncommon to get recurrences with non-solids at all along the suture line, but they do occur. And I have many cases where and it's always a question of, do we treat them like any other non-solid? Do we assume that it's a more aggressive cell type anyway? I mean, it's
Might be tricky to differentiate between a dystalectasis and a true non-solid recurrence.
Biopsy them. You get cancer cells. We biopsy everything.
Well,
But anyway.
if it's pure non-solid, probably would be more reluctant to do a completion lobectomy for this.
That's sort of our feeling also in general. Okay, here's another case. 3 time points. This is think of Rowena's talk the other day on the first annual scan, which is the middle slide. You see this lesion. We go back and look at the old scan from a year earlier, and there's this little spot right there that you can see. And then we get a 1-month follow-up, and it's grown, and this has a pretty rapid volume doubling time. And look here, just so you can, this is the coronal view, so it becomes a little bit more obvious. And you see clearly the year earlier where it was missed, but now retrospectively we see it. And so this is growing at a fast pace, right? So how much do you trust the use of volume for deciding if this is something malignant and enough to say, enough to guide whether to biopsy, enough to go straight to surgery, enough to recommend PET-CT? Nuanced approach depends on other clinical factors. And we touched on this all yesterday, but very interesting. So the audience basically is saying biopsy. Go to biopsy at this point. So the 3rd time point didn't impact you as much. I mean, if I didn't have the 3 time points, you probably still would have said go to biopsy. So the 3rd time point, which increases as far as we're concerned, I think it gets to this question of when do we say, hey, this is malignant? If I could tell you that this is 95% chance of malignancy, do we really need to start biopsying or putting them under anesthesia and doing bronchoscopy or, risking a big pneumothorax? I really think that we're at this very unusual point where surgery is going to become a same-day, uniport surgery with You know, they're already talking about discharging patients the same day with surgery. You know, are we getting, I mean, this is where the surgeons have to move. You know, you guys are getting competition now, so you've got to up your game a little bit.
Well, I think this is a lesion. I would, as a first step, go for a PET CT to see the lesion itself, to rule out there's probably any avidity in the lymph nodes, which might indicate also some inflammatory process. And when it comes to histological verification, there is a bulla right over the lesion. This is bronchoscopically maybe feasible, but tricky to reach very much in the periphery. So if it comes to histological verification, I would go for a quick VATS wedge. You have it easily verified, and it's probably less strenuous for the patient than having to undergo a biopsy with potentially a negative result, and then all the hassle associated with it afterwards.
Easy unless you have the very adherent lung.
So I have a question. Here we have a lesion that is rapidly growing, and there were no lymph nodes enlarged. I'm going to put this question to, we have an expert radiologist in the audience, Professor Kazaruni is in the back, and she needs to weigh in. What do you think the value of a PET scan would be in a case like this? Rapidly growing solid lesion, no enlarged lymph nodes. Do you think a PET scan would add anything?
No, I think the lesion is growing, it's growing at a rate. I think the only question is the rapid rate because it's not cancer, it's infection.
Right, and that's why I'm bringing out the 3 time points.
Right.
I think this is where I want to see radiology head, because it's now growing over a year and months. So I think this is where we need to get better and better. What would convince you would be my next question. To say, now I say, okay, it's still small, let's wait another month. If it continues to grow at a malignant rate, would that convince you it's not an infection? Or do you still say, got to biopsy it? And you have to think about that also. I'm saying I'll be able to tell you within a 95% chance whether it's malignant or not.
I don't think I would wait, given the growth rate that you've seen in that last short-term interval, to then check it again. I think it's showing, it's displaying its biologic behavior already. Waiting is just going to continue to increase the size of it.
So do you think that we can give a good estimate of the probability that that's malignant, given a persistent growth rate of 75 or 90 days over the course of over a year?
Well, you said...
Remember, we have the first scan, which is a year earlier. Then we have the first annual repeat, and then we waited another month to check what it is, and it continued to grow at the same rate. So now it's...
Well, the last 2 time points that you showed were close together with a relatively fast doubling time.
Right, and the doubling time from the T-1, where it was a small side, you can estimate the growth rate, and it's the same. So it's a consistent, rapid growth rate for over a year.
It could very well be a granulomatous infection.
Okay. Well, I think this is where radiology needs to head and try to sort this out. But I think that's a very good comment. I think that we're getting very close to being able to say the proportion or the percentage of what it is. I think that's where I'm dreaming radiology heads in terms of making these. And then the decision is, you may still want to take it out anyway, but okay. Let me go to another case. Here's a question for the audience. What features of growth assessment are most impactful for decisions toward decision making? Growth rate, just the rate of change, the absolute change in size over time, regardless of the rate, just so if you have 10 years and it's still got twice the size, 3 times the size, consistent size change, or the consistency of the lesion. So growth rate is the big winner. The reason I ask this is a few years ago, I showed a couple of cases where we had nodules that were small, but over the course of 15 years, they doubled or tripled in size, but the volume doubling times were, 600 days, 900 days. And the feeling by many of the people in the audience was, got to take it out anyway. This was the rate that was not so important. It was the absolute size change. Here we're seeing the idea that the growth rates, which I kind of think so also, is the most important feature. Okay, let me switch to a couple of different cases for a moment. Well, I can show this one also, I guess. This is a unilocular cyst. Here's 3 time points, and you can see that it's going from, whoops. For the most part, it's pretty smooth. That's probably a little vessel next to it at the bottom, so it's pretty smooth wall. The wall is getting a little thicker and a little thicker, and this is over the course of a decade, basically. And you can see it even has a little kind of new nodular component there. How would you manage? Continue to observe, attempt to biopsy, PET CT, direct to treatment.
Shared decision making.
Wow. So in that last case where I had a solid nodule that was growing consistently, people were more reluctant to go direct to treatment, but with this one, they're more apt to go direct to treatment. Very interesting. Any thoughts by our team here on this case?
I think this is quite typical because there's this nodularity arising in the wall of the cyst. And if my radiologist is happy, we would go for treatment without it because the chance of getting tissue with a transthoracic biopsy would be lower in this case, I would guess, and we would choose local treatment.
So here you would be comfortable going direct to surgery. Kelvin, what would you do?
It's in a very inconvenient place for a segment, between 6 and 8 segments between 8 and 9. So I would go and do a lobectomy without tissue diagnosis. I think it's relatively straightforward to biopsy these lesions bronchoscopically. You can go through the cyst, actually. Just go through the cyst and freeze the whole thing and pull it out. And I would be more comfortable to, if surgery's been contemplated, I'd be more comfortable if I have histology.
In Canada, we would want a biopsy as well. Yeah. Sorry, we're not as brave as...
No, but the going straight to surgery, the radiotherapists have a lot of experience with making those decisions. And I'm just curious, we have 2 expert radiotherapists in the audience. Do you have a sense of what degree of certainty something has to be malignant before you're going to go straight without tissue? Or in your mind, is it, if it's a 70% chance of being malignant, is it a 90% chance of being malignant? Is it a 99% chance? What's your kind of gestalt on this, or do you think of it in that way?
So my previous PhD, Dr. Alex Louis in Toronto, did a Markov model analysis, and he came to the 85% likelihood as a trade-off. And I think that's what is in some of the screening documents as well. The British Thoracic Society goes for 70% because they say that their surgical rates are so low, they're willing to take the risk, but the screening study shows they're actually doing far better. They're probably much more accurate. To me, it's the tumor board. If the tumor board strongly feels the indication is there, but the probability is low, I would say repeat it. Watch for growth. But if it's high probability in the Western model, we developed a herder model in our hospital, then we would actually go ahead and treat.
I think we have insufficient information to come to a final conclusion here. We don't know about the age of the patient, the functional status. So in the end, the radiological probability is, of course, a very important aspect in the decision and on what to recommend the patient. But in the end, this is growing over a decade. So it's a very slow progress. If it's an 85-year-old patient, would be probably perfectly fine to observe. Whereas in a 45-year-old patient, the decision would be a completely different one.
Sure.
I would say 90% for me, as my intuition.
And most of the guidelines, and they're not terribly rigid guidelines, are around that 70%, that the surgical rate for malignancy needs to be, 70%. Once you start getting into that range, you can potentially go straight to surgery. And some of the original decision theory papers that were written on this, which were first published in the 1980s by, who was it, Rowena? Cummings, and I forgot. That was the first real decision analysis where they ultimately concluded that the decision is a close call, when to do biopsy, when to observe, and when to go straight to surgery. It's kind of tough decisions in terms of what's going to yield a better outcome. Each has its pluses and minuses. But I think that there's this overall sense that we need to get higher than 70% before you say, let's go straight to surgery.
I would
But
say
I think that's what we're going to be able to do very shortly.
those changes in cystic lesions may be difficult, really, and they may be misleading. We have a case recently that we observed, and then we went to surgery. We biopsied, the biopsy was negative, and we went straight to surgery, and interestingly, hilar lymph nodes were involved. And the case was very aggressive biologically.
For us, we think about it differently in Toronto. Even our surgeons, it's if you can't get the biopsy, or it's not possible, or it's very risky, rather than the 70% or the 85%. So I think we're more conservative. But I suspect it's the same with where Dr. Leighl is.
The question is, with increasing volume of these patients, will we be able to keep the same principle? I mean, we already face the problem. Our MDT receives 40 cases twice a week. So we have to review 80 cases a week. Now, who is going to do that? Martin is with us, all the surgical team is with us, but we need to expand, but we need also to be smarter. Perhaps not biopsy everyone if there is 90% of chance. Perhaps AI will just mark 92% in this case. Yeah. Go to surgery, Dr. Rzyman.
Yeah, I like the idea of a paradigm shift. I just think there are a lot of us that you have to bring along.
Not an easy task. So here's the next case that I wanted to show. Here's a right upper lobe part solid lesion, status post wedge resection. At the time of surgery, actually, this small non-solid was left in place. They didn't want to operate anymore. It hadn't been changing. But now we see over the next 3 years in the bottom row, you can see, whoops, it's getting slightly bigger, and a new one is starting to develop. So, how would you manage this patient? Okay. The first one? I think it was about a year. And then we have follow-up over a couple of years. So we see so for the multiple, still relatively small non-solids, we are recommending multiple wedges is 12%, just a lobectomy, so for that lower lobe, which is a big surgery, or ablation only 19%, observation and adjuvant therapy got a 4%. Any thoughts?
Well, due to the location of this lesion, a wedge is not going to be feasible in the middle lobe, so it would be a middle lobe lobectomy.
Lobectomy for sure, right? What about adjuvant therapy adding to that?
I think you have to show me the money. I need the pathology report. You know, I need size, I need molecular, and then I'll tell you. You know, I think it's hard, especially with these recurrent lesions. You know, you need the whole picture. Who's the patient? What are their comorbidities? What's the chance of cure? What's the chance of cure of salvage surgery? How many other things
person.
have been left? You know what I mean? So
Sure.
these are, I mean, that's why you're presenting these. These are very complex cases. We fully support reintervening if you think you're going to achieve cure. But then again, for adjuvant therapy, it really depends on what is the probability of recurrence, and perhaps more importantly, what is my chance of decreasing that with drugs?
Any other thoughts from anybody? You know, this patient will continue to get more non-solid lesions over time. There's almost no question about it. All right, let me show you another case.
David?
Yeah.
Yeah, so if you look at the previous case, after the original limited resection and having recognized that there's a second middle lobe lesion, that's where you want to think about preventive medication, and that point, that patient should have been put onto a trial.
And a lot of these people, they have, you know, KRAS alterations. There'll be multiple tumors, KRAS G12V, sometimes C. You know, a little checkpoint inhibition goes a long way. You know, I think we all have a lot of these patients who were called stage 4 to get checkpoint inhibitors, and they're all alive now, and it's been 10, 15 years. So, I mean, I think these are, I think you're quite right. Like, if we designed the trial well, I think MD Anderson has a nice study. I don't know where that's at right now, but, you know, if we could sort of collect this experience and show the benefit, I think these would be an interesting group of patients, like, despite earlier concerns about.
Let me show you this next case, and I thought it was an interesting case. Here you can see the upper lobe lesion that was, right upper lobe lesion that was growing, and in 2014 it underwent lobectomy. But here's what else was going on. There was already, at the time of the lobectomy for the right upper lobe, there were these 2 left upper lobe lesions and a right lower lobe lesion. So now you have multifocal, one seemed to be growing. And then you can see over time now, all of them continue to grow, right? All of these are continuing to grow. How would you manage this patient? And again, this is a patient that can tolerate surgery, healthy patient. So the winner here is limited surgery when nodules are rapidly progressing. And certainly one of them, the larger non-solid lesion, certainly this one seems to be moving a little faster, but this one here is getting a little more solid. So you think we should go and do multiple wedges on this? Would you want to wedge out that big non-solid?
I think those lesions are feasible to reach with a wedge if the patient is functionally fit. And those are different entities on a molecular level. I think local therapy could still be the way to go forward, and I would proceed with the surgical resection. However, of course, adding systemic therapy is also an option here.
And just notice, by the way, this is 13 years of follow-up already. So it went from 2013 to 2026.
So I'd like to add that stereotactic radiotherapy would be an option. The lower lesion, right lower lobe, would be a single fraction treatment. The left upper lobe, which is much more diffuse, the largest lesion there, we probably have to do it with the risk of chest wall fractures, but it can be done if the patient did not want to have a second surgery after the initial right-upper lobectomy.
Go ahead.
I guess, this is a systemic or pan-lung problem, and so thinking about what's your goal? Do we really want to play whack-a-mole? Do we want to just focus on the rapidly growing or rapidly changing solid lesions, which do pose probably more of a risk to mortality? And then also, what are the opportunities, right? If you can get me some tissue, we can profile it. If they have high PD-L1, maybe I can shower them with a little checkpoint inhibition, and maybe that will make a difference long-term, or maybe there is a targeted therapy or something that when the local options aren't as feasible, we can step in with systemic. And I think we don't know what the right timing is. Again, I think we don't know what the impact is of the different approaches. We've previously shown in our work, very old work now, but there's no downside to sort of local aggressive therapy in these multifocal, in these patients with multifocal disease. But they really are, they're very individualized, and I think you really need to think about them as a journey, right? Not an isolated case of cancer. This patient's going to have this forever, and how do we maximize their quality and quantity?
Okay, I was debating whether to ask the radiotherapists a question. So if you can give me a really quick answer on this, because I want to show this last case. But it becomes my belief that when you have that bigger non-solid that you said you could radiate, but maybe you're going to get a chest wall fracture, to me, there seems to be a big difference in complication rates when tumors reach 2 centimeters or so. And that the decision is to do surgery or radiotherapy. I get nervous on radiating these larger lesions when surgery is a good option. Do you have that sense that around 2 centimeters is where it's really safe, few complications with radiation? Or am I just making this up?
I think it depends on the location. If it's more than 2 centimeters, there's also a risk of increased occult nodal metastases. So if the patient is fit for both, we say, well, we can do SABR and surveillance, but surgery up front may detect nodes which let you have it. So it's not the toxicity so much, because we have machines where we can use even smaller margins to limit toxicity. Although I see that you're putting a lesion next to the esophagus up there, but that's where we have to use different techniques.
It's what? I mean, this, by the way, is my concern with the Valor trial, where they're doing 5 centimeter tumors with radiation versus surgery. I think
well, I think it's a tumor location more than size, really, and we can do quite effectively SBRT in lesions that are 4 centimeters. The question is how much of the systemic dissemination is already, what's the risk there? But in terms of local control, it's all about the location.
Okay, I'm going to move on to the next. This is, I think, going to be the last case I'll show. And one of the, well, I'll tell you in a moment why I'm so interested in this case. So here we see case 7, healthy young person, 50-something years old, left upper lobe lesion, right upper lobe lesion, right lower lobe lesion. And they were very slowly changing at the time. So how would you manage this patient? Now you know why I like this case, Natasha or Karen. Yes. 91% just said keep observing. Let's just keep watching. You know, 2 years ago at the first Agile conference, we had Alexander Echermont, who was mainly a melanoma guy, but he was the director of the Gustave Roussy. We were showing him stage 1 lung cancers, and he was adamant that if it was him, he would not want surgery, and he would say, absolutely stay away from those lymph nodes. Don't do lymph node resection. He wants immunotherapy up front. And then he would say, maybe take out the lesion, but don't touch those lymph nodes, because that's how you're going to get a cure. And I remember talking to the surgeons at that time, and they all said, this guy is nuts. This is absolutely, not the way to go. And I should have had that as a poll question, because I listened and I thought also that this was a little crazy. But I think this is where this could be heading. I really do, and I think these are the lesions where we really need to be thinking about it. So everybody wants to observe at this point, and I get that. But let's just move on a little bit. And so now, I forgot how many years this is in between, but now this is in 24. Let me just see what year that was before. This was in, 05. So this is a long time. We watched this for a long time, 05 to 24. So we've been watching this, and now you can see what's happened. They've all grown, some a lot, some a little. Yeah, 19 years. Asymptomatic. Now, how would you manage this patient? And yes, shared decision-making is always, this patient, can say, hey, I don't want to go near anything. I've been feeling great. It's been 19 years. I get that. But what if we had but other patients I have with this situation that we tell, because in the screening world with these non-solids, Claudia has always gotten very involved with the patients, and they call her directly, what should I do, what should I do? And when we say, it's growing, but come back next year, it's safe, and yes, it's probably cancer, right? That's a hard thing to sell. You keep telling them, come back next year, did it get bigger? Yes. So what do we do? Observation, whoops. Oh, so we got answers already, my goodness. 67% biopsy and consider targeted therapy. Well, this one I'm going to ask Natasha and Karen to weigh in first. And I really want to hear what you think about these patients for vaccines also.
Sure. So, I'm ashamed to say that we'd probably keep watching if the patient were asymptomatic. But I don't think, I think, a vaccine strategy or trial is very interesting. The challenge with a patient like this, of course, is do you need to make it personalized or not? There are some off-the-shelf vaccines with growing promise. But I think for, the really sort of super duper latest technology, you would have to get a piece of this. You would need enough that you could sort of identify the epitopes and generate an mRNA vaccine.
We can get enough. We can go in, that big lesion, we could go and get 10 cores and whatever, and Kelvin would grow an ice ball the size of your fist and pull it out through the bronchus. So.
And then it's also, can you find what you need in that sample to generate the vaccine? So, both of those, that I think a less invasive approach would be exciting. Again, for this patient, it's a journey, right? And you guys have done a great job of maximizing both the quality and the duration. And so how do we not screw it up at this great point, right? We're turning on 20 years. How do we get another 20 years with minimal damage to the patient and maximal benefit? So I would love, if they could enroll in a vaccine trial, checkpoint inhibition, right? If you got high PD-L1 for us. Targeted therapy, sometimes these patients do come and they have HER2 insertion mutant lung cancer. It's less common. Those things tend to be less aggressive, or they have something with KRAS. Not as excited about the therapies, and I'm still more excited about immunotherapy in that group. But it is interesting. Still in Toronto, I think we just keep watching. I don't know. What would you guys do?
Well, Karen, let Karen first.
So I would, first of all, I think we do need to understand the biology of these lesions. Are they the same? Are they different? Because even when you think about a vaccine strategy, as you alluded to, it does make a difference, particularly, again, either way. Whether it's personal vaccine or it's an off-the-shelf vaccine, the off-the-shelf vaccines may have 5 tumor antigens, tumor associated, but are they the right 5? Are they the right 10? Would they be the right ones for all of them versus one of them? So, and then personalized vaccines, mRNA vaccines, again, you would make it to the one. Would that affect the other one? So I do think we need to understand the biology. And when I would say that when they're making these off-the-shelf vaccines, again, it's not to some ground glass part solid, it's to solid nodules. And those tumor antigens may be completely different than the tumor antigens here. So I think here one would need to, if you were going that route, a more personalized vaccine. But as you know, it's only the antigens, which are not very many, that will stimulate that immune response. And so perhaps going that route, you'd have to have a personalized vaccine made. An off-the-shelf vaccine, I don't think would be the right
That's what I'm saying.
strategy.
Let's assume we can get the tissue. Let's assume we can, do the sequencing and we can find some antigens. You think this type of case is the right case for it, for a vaccine? This is
it's
slow growing.
Very slow growing.
Still a low volume of tumor.
I think it could be, but you may not, again, get all of what's really the goal? Are you trying to shrink? What are we trying to do?
Tell the patient it's not growing anymore. I can't sleep at night, Doc. Every time I see you, my tumor is getting bigger. It's a real challenge. I mean, you probably go through this.
So maybe I can say about the last patient whom I persuaded not to allow it to be treated. It was GGO measuring 3 centimeters in the left hilus, and the tumor board in another city felt it should be treated. So I asked the 70-year-old lady whether she had plans to go for a hiking holiday in Australia or something. She says, why? I said, well, do all the things you want to do which require your fitness, because by the time I finish, you're going to be less fit. Because it's a parahilar 3-centimeter lesion with at least one airway close to it. And then because it's more than 3, I'm happy to treat it. So that gives them some control over what amount of collateral damage they can expect as opposed to their plans. It's very difficult because some of them really cannot sleep but that's why I cite the MILD data and I say, well, 7 out of 10 unfortunately occurs in another place than this. So we follow you up. We could do the appropriate local therapy, which is parenchyma sparing. And it's not easy.
I'm glad nobody suggested any platinum-based regimens for this. I don't know.
You're safe.
It's a little joke to the oncologists. But things have so dramatically changed in the past 10 years. It's really spectacular to watch the way the field is changing. Even these discussions, we've been doing these therapeutic panels, the discussions are really, really rapidly changing. So we're concluding at this point